We're just waiting on the arrival of Dr. Shehenaz Mohammed, the chairman of the North Central Regional Health Authority. So stay tuned for that. She should be here any minute now. But before Dr. Mohammed comes to Nili, remember I started telling you about that story, Dr. Fuad Khan, the Minister of Health, and the Sextuplets. The story is written by Anna Ramdas in the Express newspaper. And the story says the sextuplets' parents are ungrateful and owe the government, the Prime Minister, and the taxpayers of this country a thank you for all that was done to ensure that mother and babies had the best care possible. The words of Health Minister Dr. Khan. So you did ask this morning, did he use the word ungrateful? Well, yes. So, because he's quoted as saying the sextuplets' parents are ungrateful. And they owe taxpayers, government, Prime Minister, everybody a thank you. Well, apparently, according to a Guardian newspaper report, the father of the babies, Mr. Kieran Cummings, said he regretted not taking his wife abroad as he was dissatisfied with the aftercare at Mount Hope. A very upset Dr. Khan, speaking with the Express, took issue with Mr. Cummings' statements. He said, I hope he doesn't have a complaint about the house now that he has gotten, the house that he has now gotten from the government. I wonder if he will say that the room is too small, or they need air conditioning, or they need another story put on. Looking at their method of approach to what the health sector did for them, and to know what is happening now, sometimes people have to be grateful in life.
Well, they're being ungrateful.
Yeah, but he used the word ungrateful, according to what Anna writes. He said not only were millions spent to ensure the babies had first-class treatment, great sacrifices were also made as other babies had to be accommodated at the Port of Spain General Hospital and the San Fernando General Hospital when the sextuplets were at the NICU. I think at the end of the day, when people get things easy, they don't appreciate it. Questioned on the aftercare of the babies at the NICU, which Mr. Cummings has taken issue with, Dr. Khan responded, according to the head of the neonatal unit, Dr. Kamani Lachman, she indicated to me that the aftercare was on international standards based on all the things we put into place. Now at the end of the day, one has to ask, what is the motive? Why are the parents doing this? That's Dr. Khan. Time has come to actually tell the government of Trinidad and Tobago and hopefully the Prime Minister, thank you for the house when other people didn't get it, and thank you for bending over backwards to assist us. He's saying this is what the parents should be saying. He questioned further how exactly was Mr. Cummings going to afford international care for his wife and babies if he had to apply for government housing and depend on the HDC for a home. Dr. Khan said the public health sector strives to deliver the best care possible for all patients and will continue despite the negative comments from persons who are ungrateful. The use of the word again. He said further that the pregnancy was not a natural one as fertility drugs were used. One has to investigate the use of Clomid. This is Dr. Khan speaking. Clomid brings out congenital birth malformations. He stressed that in these pregnancies where the babies are premature, there are numerous complications and therefore it was unjust to blame the health system for the 2 babies that died. Dr. Khan said studies were done on the drug that needed to be looked at. According to a report on the website, and the story goes on to the U.S. Food and Drug Administration labeled Clomid as a drug that should not be used in pregnancy because it raises the risk of major birth defects. Now, I remember
and that's
when
the drug that was used, right?
Yes, I remember when the Clomid issue came up right after the birth of the babies. And they were saying that she was not taking the drug.
At first, there was no discussion on any fertility drugs.
Yes.
We eventually found out, Dale.
Yeah.
We eventually found out. That was not the first story that broke. We just told that this thing, and then as the information began coming out, then we got word that there were other things playing out in this rather peculiar situation. So, right. So here is the lovely lady. Morning, ma'am.
Good morning.
Morning, Doc.
We said we have been waiting. We have been waiting on Dr. Mohammed.
Is this an entourage?
She has brought her entourage. Oh, there's more.
No. Is it? That's why it's there.
So let's get. Right, so let's settle in the ladies, all beautiful ladies with us this morning.
My goodness, this is
N.C.R.H.A.
This is not Miss Ministry of Health, you know. Yeah.
Anyway, Dr. Shehenaz Mohammed is the chairman of the North Central Regional Health Authority, and she has brought with her colleagues. And we welcome you all to our studios, and thank you very much for coming this morning. I know you had to change around your schedule to facilitate us. We appreciate that. Thank you very much.
Yeah,
and I was
so
just
all these wonderful ladies come closer to the microphone.
Right.
Should I introduce them?
Yes, that would be nice.
Right.
Thank you very much.
I have Dr. Kamini Lakshman.
I just called
your name.
Dr. Lakshman.
This is the lady.
You're in an article this morning.
Okay, I haven't had the time to read any of the papers this morning. Oh, sorry.
Come right up.
Right.
Come right up, doctor.
Okay.
As close as possible.
So, Dr. Lakshman.
Right.
And on Dr. Lakshman's left, I have my general manager of nursing, Miss Rosalind Renault.
Right.
And next to Miss Renault is my matron of Mount Hope Women's Hospital, Sister Utica Fraser.
Sister. All right. So
Utica.
2 docs and a sister.
And a nurse, 2
And a
nurses.
nurse.
2
All
doctors,
right.
2 nurses. Yes.
I have, welcome
The only
again.
person
Thank you very
missing
much.
is Fuad.
Good to see you. It's been good to
He
see you.
sends his regards, sir.
I'm just reading an article which spent a lot of time quoting Dr. Khan, the Minister of Health, on the issue of the parents, or at least one of the parents of the Sextuplets, Mr. Cummings, and his statements. Did you read his statements as the chairman of the N.C.R.H.A, which was really the body overseeing these births? What do you think of what he said, what he's quoted as saying? Not Dr. Khan, Mr. Cummings.
Those were the statements pertaining to...
Where he said he was not entirely pleased with the aftercare that the babies received.
Right. I think his statements were unfortunate. The best person to address the aftercare and what he's complaining about would be Dr. Lakshman and Matron. I think his statements are very unfortunate based on what was provided for the babies. And I maintain that provision was at international standards for the care of these babies.
In fact, Dr. Khan is quoted as using the term ungrateful, that they are ungrateful. Do you share that opinion?
There's no politically correct way to say this, sir.
Well, just be correct. I don't want you to be politically correct. I just want you to be correct. Do you agree with Dr. Khan, the minister, when he uses the word ungrateful?
Yes, I would have to agree. I would have to agree, and you will probably agree with me afterwards when my nurses and my doctors tell you to what extent they went through to take care of these babies, to take care of mommy. Ungrateful is a harsh word, but it is a word that Dr. Khan has used following multiple attempts by the family to, I think, bring down what we have put in place for these babies. Dr. Khan did not say the word ungrateful just like that. It came after many comments, many adverse comments from the father.
You think they're being malicious? You think it's ill intent, or you think it's the burden of this trauma that they're going through?
It's a multiple of factors, and mommy and daddy are young, and I think they may be misguided. I really cannot say that daddy himself is thinking of all of this on his own. I think he is being misguided.
Now, maybe Dr. Lakshman can come in here. You would have put just about everything in place. I remember the very first news conference that prepared the country for these births. And I remember you all being very, very careful in saying what is going to be done, how it's going to be done, and also protecting the identities of the parents. Are you sharing the same view that there is some level of ungratefulness here?
Well, I think that the parents, they are grieving, and there's a lot of factors that are going on. I also think that whilst we don't expect gratitude for what we do, there needs to be recognition that everything that could have been done has been done, and that even though when we first became aware of her case, we had deficiencies that needed to be addressed simply because of the burden of dealing with 6 resuscitations at one time, that thankfully we had the support from the minister, the board, the administrators, even the doctors and nurses individually, and all levels of staffing to rush and put things in place so that we can cope with this event on a level that is acceptably internationally, and more than just acceptable, in keeping with international standards.
Did you expect, or did you all anticipate as a team, did you all anticipate deaths?
Yes, we did, and in fact the parents were well counseled about that at all levels. On my very first interview with Ms. Lifun, I counseled her on all the complications of prematurity, including the death of more than one, any number up to 6 of the fetuses, including maternal mortality also.
Do you think that and any one of you can come in here, Ms. Renault, or is it Ms. Fraser? Any one of you can come in. Do you think that the deaths of the 2 babies would have toppled things a bit? Because you started hearing the words of Mr. Cummings only after, at least for me, only after the death of the first baby. Started hearing things. You started hearing that there was dissatisfaction somewhere, and then the second baby died. Do you think those deaths may have changed things?
Well, I can answer that. I think Mr. Cummings or his family, their complaints were coming into the minister from before that with respect to going abroad for treatment, and I think that is what the minister is alluding to. The ministry, they were requesting the ministry to embark upon paying for care abroad, and we had the expertise here. Our capacity was in, as Dr. Rachman will indicate, was in increasing equipment and increasing capacity for 6 simultaneous resuscitation. With the guidance of the minister and with my board, we engaged in discussions with the professionals, and we put everything in place to be able to achieve this. Dr. Rachman will make the point as well that much of the equipment that we bought, not the consumables, but the capital expenditure on equipment, will remain in the neonatal ICU and will also serve other babies, many other babies.
And not necessarily multiple births.
Not necessarily multiple births. So, Mr. Cummings, that side of complaints will come in during the pregnancy, but not necessarily reaching the newspapers.
I wanted to, and I don't know who's going to answer this. You talk about the purchases made and the investments, so to speak, and that I'm glad to hear that a lot of the equipment purchased would be used as we go forward. My criticism of this, and while I don't want to knock you for preparing yourselves, but my criticism when I saw the spend, I thought, but why aren't we spending as well and being as quick in our spending and acquiring other pieces of equipment that are absolutely necessary? Dialysis machines come to mind immediately, and we talk about it.
I'm ready for you.
Yes.
So you're ready for me? Beautiful. Let me take it from here then. No, but I want to get to the
so I wanted to come back to that.
Yes, we will, definitely.
But in terms of having the one-on-one care with the parents, nurse, tell us.
In relation to the one-on-one care, because internationally, in any NICU, what is recommended is 1-to-1, 1-to-2. We offer that service at Mount Hope Women's Hospital. We got nurses, the management assisted in with whatever we required. Sometimes if we don't have the numbers, we have a system of pool where we have extra nurses coming. So we are sure, especially in the critical days, those first 3 days, that 1-to-1 care was offered to each baby, in addition to the others we had at that point in time.
So your statement is that at all times you all were best practice.
Best practice. And we have to remember, this is a specialized hospital. Those babies were prepared for many weeks prior to the delivery. We all became, and this is why nursing is really much surprised and probably a little bit hurt, because we became a family. We were the first ones to hold these babies. Both in the midwives received these babies in the theater. The NICU nurses received them in the neonatal unit, and they got excellent care. Everything was provided. The nurses, up to yesterday, we did feel a little bit disappointed and hurt, because yes, there were 2 deaths. Even in death, we were at the services. Even in death, we were with the families. We ensured even on discharge that primary care was there to take up the continuity at home. They are coming back to the clinics at hospital currently. So as the nursing administrator, I felt a little bit hurt, and in communicating with my nursing staff, the feeling is there. I think I was told yesterday on one of the newspapers, the mother said that she got good treatment from the staff. We ensured prior to delivery, she was communicated with from all aspects of care. It was a holistic care. The breastfeeding coordinator, the medical social worker, the pharmacist, the entire team was involved in the management. Pre and post care of the mother. So I will be very surprised if she looks me in the face and tells me she didn't get good treatment. I will be surprised if she does that. The babies, I continue to say, got excellent care, first-class management in the NICU. I don't understand where the complaints are coming from. I really don't.
I also do not understand where the complaints are coming from, because from all what I have been told by both parents, they were satisfied with the care. The nurses went beyond the call of duty, and they will continue to do their best for not only that family but for all families, because throughout everything, all patients got excellent care. We maintained good nursing practices, and we ensure that we continue to give the care and support to all of them. Like Matron said, even in the primary care setting, we ensure that the mother and babies are taken care of, and we'll continue to give them the care in the clinics, and we'll follow them up, and we'll support them throughout, because we are a caring profession.
May I say something? Just so that we understand, this was not simply dealt with by Mount Hope Women's Hospital. It took a lot to get this done safely and at international standards. The 2 ICUs in Trinidad, otherwise San Fernando General Hospital and Port of Spain General Hospital, the heads of the ICUs, Dr. Vanessa Stewart and Dr. Barry O'Donoghue, were very, very cooperative and helpful for quite a long period prior to the delivery of this patient. Our services needed to be downgraded, which means that any high-risk patient that came to our institution had to be transferred intrauterine to any one of those institutions, burdening their service to allow us to block and keep 6 spaces, 6 ventilators, 6 beds for this particular case.
Do you believe, Chair Lady, that this has put a stain on the work that you all have done? What is playing out now in the public, and the use of words like ungrateful, the father says he preferred to go abroad. Has it stained this entire, what at the first was a very happy moment, is now staining this scenario?
No, I don't look at it as staining the scenario. That's the nature of healthcare. In healthcare, there's morbidity and there's mortality. In healthcare, the emotions run high because you are dealing with people that you love. Their risk of death or death. You're dealing with illness. You're dealing with things that may disable you, things that impact on family life. So with healthcare, there'll always be good news and there will always be bad news. And I think as healthcare professionals, you are trained to keep your eyes focused on giving the best care that you can to minimize mortality and minimize morbidity. But at the same time, you recognize that we are mortals and that it is, again, there's no politically correct way to say it, but patients do succumb to death. The question always arises that they get all that is humanly possible and scientifically possible to ensure that the best outcome is provided.
Is it true that the aftercare cost? I saw the newspaper article this morning. Is the figure correct?
That figure,
$1 million?
That figure is correct. That figure has been calculated by our finance department. But what I would like to add, and Dr. Lutchman will, she can attest to this, is that is the care of babies, premature babies. That is what we pay for that neonatal ICU. Once we have a baby on a ventilator, that is what it costs the country.
So this is not unusual?
No, what we are trying to say is that the aftercare was no different, correct me if I'm wrong, than the aftercare of any premature baby. The cost of the aftercare was no different from the cost of any premature baby, and therefore the risks pertaining to their aftercare were the same as any other premature babies.
Is it that it costs approximately $1 million aftercare
per baby?
Per baby?
No,
so this will be 6.
That was 6. That was all 6.
Oh, so the total, okay.
Okay. So then an individual baby
divided by 6.
Divided by 6, yeah. But when you look at the medication involved, again, Dr. Lutchman will attest it, you're looking at medication like surfactant.
Okay, surfactant is used, we put it into the lungs so that we can allow the baby's lungs to work properly. When you are very preterm, especially when you are less than 34 weeks gestation, all your organs are very immature, and therefore one of the major risks with prematurity is the risk of respiratory distress syndrome, where your lungs do not produce surfactant, and therefore we need to purchase it and put it into the lungs to allow the baby to breathe and to put them on the ventilator and then breathe for them until they can mature and they can do it for themselves. That is just one of the medication we need to use.
Surfactant is costly. These babies also got immunoglobulins, which is also very costly. So cost is not spared in the neonatal ICU to provide whatever is needed for the survival of the babies. But again, with every illness, there's a risk of mortality and there's a risk of morbidity, and we try as much as possible to limit that risk, to reduce that risk, and to remain within what is recognizable as statistical international standards with respect to it.
You're quoted as saying that this is the result is an international result,
and you did talk about the prevalence of these births when they occur internationally. Mm-hmm. And I also went online and pulled down some stuff, and I saw where up to July 2012, at least in 2 countries, Afghanistan and Thailand, the births occurred, multiple births, and all survived.
Well, I'm not a neonatologist. I'm advised by my professionals, so the best person to answer this question will be Dr. Lutchman.
All right. Because of the small numbers and scattered all over the world, there aren't many studies on sextuplets. But what I have found is that up to 2012, there were 187 cases reported of sextuplets. Out of that, approximately 35 survived and went home as 6.
All 6.
Right, 35, which means approximately 1/3 of that population will go home as all 6. The other 2/3 will have more than one or more than one deaths. And of course, the long-term complications for all of these will be incredible. Even the ones that went home intact will be extremely high. The other thing that I also found, even though I didn't have figures, is that out of those who went home intact, or the ones who went home with one or more deaths, that the survival rate into infancy was greatly affected. So compared to singleton deliveries, their survival rate was worse.
So you maintain that we have done well?
I think that my staff, and I'm speaking about every level of staff at Mount Hope Women's Hospital, has done incredibly well. A great personal sacrifice too, because of, in terms of being on call from 23 weeks gestation, not being able to go out, being able to do the regular family things because you needed to be within a 10-minute radius response time to deal with an emergency delivery. A great personal sacrifice. All levels of staffing has been invested in this delivery and have done their best, and we have done what is in keeping with international standards.
My nursing manager will tell you that not that missing carnival is a personal sacrifice, but she instructed all of her nurses that they are not to partake in any carnival activities, they are not to drink, and they are not to be at any party. They are to remain at home.
You must have been
and,
I think,
and they have to be within a 10-minute radius of the hospital.
and that was my instructions to my doctors too, and they were not very happy about it, but they all did it. And they all, I mean, we might have griped about
You
it.
took away our wine from people?
In more figuratively and literally.
We even provided accommodation for staff who had to come from very far just to ensure that they will be available and they'll be around. So we had emergency plans in place and we had elective plans in place. So all systems were put in place just to ensure that everything went well and we were satisfied with the outcome. It went well.
How is Persia doing?
I will let the matron answer.
All right. I wasn't able to do rounds on her this morning because of this, but when I looked in, she has been ill for the last few days, but she's slowly improving, and we look forward to her continued improvement.
So the
That's a
parents
beautiful
are
answer,
still,
David. That's a very beautiful.
the parents are still in and out. And
I have not seen them for quite some time because they come in the night. I have requested through my staff that they come in during the daylight hours to speak to the senior doctors. After 4 p.m. we have emergency staff, so we cover all the emergencies on the ICU and births department, in the emergency room and operating theatre. So while parents who are on the ward, they're allowed to visit, all parents are allowed to visit until 10 p.m. But if you're on the ward at 10 p.m., by 10 p.m. during that period, and the staff that is on call or in the hospital are not involved with an emergency, then you will be updated. However, to get a proper update, you need to come in during the daytime period when all the staff is there.
Okay, now we are talking with Dr. Shehenaz Mohammed, the chairman of the North Central Regional Health Authority, and her team. She has brought with her this morning. I want to come to the issue of regional health authorities, and in this case, the N.C.R.H.A. and its ability or inability, as it may be, to acquire needed equipment and resources to manage hospitals and health institutions.
Okay.
We see that a lot of investment was made here, and as I said, but why they can't do this generally? Am I unfair and unreasonable?
No, but it's a question that I asked when I assumed the chairmanship in November. It's the same question that I asked. Before I go into this, I must point out, as the chairman of North Central R.H.A., we are talking about how much work we have done, but I must let the public know that Port of Spain and San Fernando also did a lot of work. They were not involved in the delivery of the sextuplet, but they bore the burden of having to take care of all the other mothers and babies while giving us the opportunity to do this. And at the same time, there was no obstetric team at Sangre Grande. So deliveries from Grande as well were burdening Port of Spain and San Fernando, and I think they also have to be recognized, the teams there. Now, when I assumed the chairmanship at the end of November and December, and I started with an open door policy. So I started to meet the medical teams, the engineering teams, laundry. I listened to everybody. And the same question came across my mind. Why are these people not getting what they need? Why is it so difficult? Is it an issue of funding? Is it an issue of accessing the funds from the ministry, or what is it? It really got me very confused and upset why this wasn't happening.
Because you would have worn another hat.
I wore another, and I complained. I spoke about problems in the health sector, and one of the major problems which this experience dealt with was that disconnect between the clinical providers, the business managers and the management and the ministry. Because if you don't have that connection with the clinical providers to know what they need, how on earth are you therefore going to set about to give them what they need? And I tried then to remove that disconnect, and this was a perfect example of how that disconnect was removed. In that process, I have also embarked upon taking care of other departments like child development clinic. We have put through purchases for what they need. Neurophysiology department. We have a neurophysician who has been working for 2 years without equipment. I met with Dr. Isaac, the board met with Dr. Isaac, and the CEO was advised this was the list. It has already gone through tender evaluation. We will reallocate funding and get this done, and we did that. Now, when you look at money that you're given for the year, if you don't utilize that money, it is returned. So what we have done is we have looked at things that we cannot get done within this time. It's already, by the time we started, it's almost close to mid-year. We can't get a lot of capital projects done with respect to big buildings, so we can reallocate that funding towards equipment. And I brought a list here. There's a lot of equipment that we have reallocated funding that we would not probably have been able to utilize in this year, and we have gone to purchase many equipment, medical equipment that has been asked for, has been evaluated, has been approved, and no purchase order put out. So we have done that. And I intend to.
And why has no purchase order been put out?
Well, with my other hat, you would have heard me complaining about mismanagement within the RHAs. And what I have recognized there, that disconnect has to do with the level of management and the level of understanding of what is needed. And there's a certain level of, we always talk about square pegs and round holes there. And my board has made a commitment that we're not there to fire anybody, we're not there to terminate anybody, but what we have found is that there are many people who are overqualified for the positions that they have. They are not in the correct positions. And then there are people in positions where they don't hold the necessary qualifications for that position.
So these positions which you speak of were made when? In the last year, 2 years, 3 years, 4 years?
These positions, many of these positions have been long-standing, very long-standing. And when you go back to the history of Mount Hope, you'll realize that Mount Hope first started off as a private facility. It was not part of the public health sector. So there are people who have been working there for a long period of time.
Doing it the wrong way?
Well, they've accustomed, yes. They've not been integrated into the public system, and they don't know the rules of the public system. And they have not gotten there by virtue of qualifications, but they have gotten...
Nepotism?
No, well, I won't say that, but they have gotten positions based on being there for a long time. So because of seniority, they go up the ladder, but may not necessarily be capable of that position.
Also, are you going to continue to have square pegs and round holes? How do you intend to deal with that, Chairman?
Well, when I started as chairman, the board and I recognized that all of the general manager positions were either empty or had people acting in it, and the people who were acting were not qualified for the positions. So we set about to interview. So we have hired competent general managers. I have an acting CEO right now who's very competent. So we're putting together a management team. Now this management team has to be responsible for guiding the management and administration below them the correct direction in which to go. Now Mount Hope went from being private to semi-public, semi-private to now completely public. So there's a lot of training and understanding. And that came about, that became very obvious as well to us when we asked for the business plan for the next year. When the board saw what was presented, there was clearly no foresight for the next 3 years in which direction we are going to go. So therefore, the problem was communication, and communication with the end providers as to where they see their department going. And I go back now to this experience with the Sextuplets. It was that communication with the end provider, and it was facilitating and this end provider to get the department up and running is what we can do. Now, my board has said that we need to spend the money on healthcare. The problem in healthcare is funds being diverted into things that are not related to patient care. And I'm talking about contracts for construction and for grounds and these other things. Now, these things may be necessary.
But who are the persons making these decisions?
You want me to call names, and I can't call names on the radio.
But it's the people's money, Chairman. It's not
necessarily names, but their positions and where are they?
These are my position. Once it has to do with these people's money, I don't see the need to be hiding anything. I understand the predicament that you're in, but if you're making a statement that bad things are happening, then we need to tell the public who are the persons making these bad things happen.
But
go Go ahead, don't be afraid. Dr. Khan won't fire you.
Because these are the people that are still in these positions, and therefore they can still influence.
I can assure you that these people are no longer in those positions.
So how have you gotten rid of them then?
Yeah, you didn't terminate, did you?
You didn't just be like a bull in a china
Can I
shop?
tell you that the matters are sub judice at this point in time?
Oh, so you
Alright,
fire
well,
them and they take it to court.
No, that I can tell you categorically is not true.
Well, why would it be? Why would it be?
So some of them have legally challenged their
No, nobody has legally challenged. I do not. I came from an industrial relations background.
Well, we know that.
I will not do something like that where I can be legally challenged.
So how were you able to...
Come on, let's go to where we are, the positive things that we are doing.
No, but there are negative things we need to talk about. How were you able to make the
You see,
change? Let me use a nice... How were you able to effect the change that you wanted? Go ahead, Chairman.
You create an environment of productivity and an environment of accountability and transparency. When there's an environment of accountability and transparency, people who can no longer account suddenly disappear.
that sounds very clinical.
So you're already chairman.
I am a clinician.
So can I say you're Chairman Houdini then?
No.
They are welcome to Chairman Houdini.
No, but she's saying they just disappear once you create the right environment.
Where
do they go?
They're gone.
Do they go somewhere else and continue the
You
practice?
realign, you reassess.
When you demand accountability, when you demand transparency, when you review all contracts, when you go back to tender, people
fall out of the system on their own accord.
They fall out on their own accord. They either resign, they either go on leave, or they fall in line. And the thing about healthcare is you have to have strong leadership. Once the leadership is directing, giving you the direction in which it is going, those people will fall in line. You know, it is unfair to say that everybody is bad. The majority of people I have found in healthcare want to work. They want to do what is best. They really do care. It is the bad apples that probably seem to make it bad for everybody. But the leadership is the key. And the functioning of the ministry and the R.H.A. is also key. The ministry is to provide policy and direction. The R.H.A.s are to manage the resources in which it is given. The ministry needs feedback, however, from the R.H.A.s to be able to access funding from the Ministry of Health. The R.H.A.s need feedback from the ground staff. That is where the connection has to be made.
All right, so I want to get now to
You want to see things.
No, I want my dialysis matter.
Right.
How many dialysis machines we have in Trinidad and Tobago? Oh, let me not bring
let's
you
go under your
particular
would you be able to say
management.
How many functioning?
I did not get that information for you with respect. I came. This is you can have this one. This is everything I bought. But
you said you came prepared. I said all right.
We are in the process of having a dialysis center. I do have 2 nephrologists working at Mount Hope, and we do have machines, but I cannot tell you. I can't tell you off the top of my head how many machines are working. The problem with dialysis is it's multifactorial. It's not just a matter of having the machines. It's a matter of having the skills to run the machine.
Right,
and it's not just the doctors. It is mostly the nurses. And we have a shortage of nurses that are trained in dialysis. And we have to embark upon training the nurses. And that's why my nursing manager came prepared to answer that as well. We have to... No, I won't deflect.
Right.
But we have to embark. We are short of nurses, one. And so they're trying to increase the nursing, the outputs of nurses from the nursing school, both COSTAT and Ministry of Health and the University of the West Indies. Of course, the standard has to be maintained, but we also have to draw on senior nurses and train them into specialized fields like dialysis, hematology, and cardiac care, because we are embarking now upon starting cardiac surgery in-house on next week, Tuesday. It is not going to be done public-private partnership. We are not paying fee for patient. We are developing it in the system.
That's what I was looking for. That little opening you just gave me there. You know, there's a clear opinion on the island that, for whatever reason, skillfully done, a lot of things are sent to persons in private practice who are also practicing in the public hospitals. And the issue is that it's not by chance, but calculatedly so. And it brings me back to the dialysis machines.
Mm-hmm.
I know you said that you can't give me the details, but I want to record today that you're going to give me an outline of what, under your chairmanship, you're going to do with dialysis in your region. So I will make a note of it mentally, and hopefully one day, in a few months, you'll be back and we'll have a second chat.
Unfortunately, the matter with dialysis, because of the there's certain issues with it, that matter has been sub judice, the dialysis center. That matter is before the courts. So there's a lot of issues dealing with that. With respect to Mount Hope itself and dialysis machines, I have met with the physicians, I have met with the two nephrologists, and they have also been asked to guide me on what they need to improve their department in the complex. And the one thing that they need is trained nurses. So I myself I can't get trained nurses. I have to embark long term with the Ministry of Health and with COSTAT to encourage nurses to go and be trained in dialysis.
You know the reason, Chairman, why I have brought this up repeatedly? Because I've been sitting here for a long time. And what I'm saying to you, I've said, like I said, the year before, government come, government go, the next one will come, the next one will go. And the people who are suffering and who need these machines cannot comprehend, with all these billions of dollars allocated to the Ministry of Health, why they can't have machines.
Plus the surcharge that we pay every month. I think a lot of people.
And I know you have to be politically correct, but I just want you to be correct.
I am being correct. The surcharge goes to the consolidated fund. The management of the funds that go into healthcare is a different story altogether. But let's go back to the dialysis machines. I talked about it's a big problem. It's dealing with trained personnel as well as the machines. Having the machines, which is what happened in Mount Hope for many things. It was a white elephant, and there were many things bought, contracts given, money made, and machines sat there without anybody to use it. And we don't want to embark upon that. Now, when you look at healthcare, and I always, with my other hat, you would have heard me talk about healthcare being destroyed, and the public healthcare being destroyed, and healthcare is public goods. And when you look at developed country status, they talk about health and education as being the rights of the citizen. When healthcare, along the way, and you're looking at commissions of inquiry from 1937 to 1938, 1957, 2006, reports all along, none of them have said anything different. They're all saying the same: 75 years of misuse and mismanagement in the health sector. And during that time, while you are mismanaging and abusing what you have at this basic level, healthcare and the standard of healthcare and technology has advanced and gone beyond what you have. And the private sector has developed it, but it hasn't been developed in the public sector.
Well, many believe, Chairman,
that's
solely
have
it so.
No, but when you try now to bring it into the public sector, it takes strong leadership and it takes planning, and then there will always be challenges. There will be challenges to incorporate, like I am having challenges to incorporate cardiac surgery into the public sector, because it has always been something that was
where are the challenges coming from, Chairman?
The challenges will come from those who shall be affected by it being part of the public sector. But when you look at cardiac disease accounting for 45% of the admissions into accident and emergency, you have to develop that service. Now, healthcare and funding for healthcare is not limitless. There's a finite amount that you get every year to spend on healthcare. And therefore, you have to develop your basket of goods and what you are going to invest your money in. We cannot invest money in every single illness, because if you pay for what you don't have here and you pay for everyone to go abroad, money goes before you can take care of everybody. So you have to look, let's say you look at the five highest causes of mortality, and you spend funding into that. Cardiac disease is the highest cause of mortality in the over 35 age group. We have to invest money into that. In diabetes and chronic disease, we have to invest money into that. So it has to go with planning from a broad perspective, a bigger picture.
You keep talking about lack of leadership. Is it that the leadership that you are talking about, you intend to fix that?
No, I think Dr. Farhad Khan is a strong leader. He has foresight.
But and independent Senator Ram Kissoon has described him as he shouldn't be there.
But that is one opinion.
Okay.
And my opinion is different, and I think the information is out there. I think the public will decide, but I think that he has shown strong leadership, much stronger leadership with dealing with health care as opposed to what has been pertaining and obtaining in the past. With respect to what I'm seeing now with contracts being given out, that does not amount to good health care coming down to the public. What we have done under Dr. Khan, the money that is going towards health that has been dedicated to the Ministry of Health is to be used for equipment. It is to be used for healthcare personnel. It is to be used to hire staff if we need staff. It is not to be used on contracts for, exorbitant contracts for grounds and plants, etc., etc. It is to be focused on healthcare. And that is why in less than 6 months, all of these purchase orders have been issued for equipment that it's already gone through the whole process. It wasn't issued. Why?
All right, now we're going to have to stop.
We have to stop.
I want to get you back here at some point in time.
We must. I look forward
because I'm also
another meeting with the good chairman.
Curious about how the regional health authority, yours, has interacted with private health institutions in the region. How much of sending from the public health system into the private health system have you had to do?
I've stopped it.
You have stopped it?
I've stopped it. We will build capacity. When you build capacity, you maintain capacity. That money is spent in the system and it stretches further. You can take care of many more patients, because when you outsource, you're paying other administrative costs. You're duplicating and triplicating administrative costs. We have expertise. We have skills. It brought tears to my eyes when I saw what the doctors and nurses, they treat patients without that support. We are here, from Dr. Khan, come right down to the chairman, the board, to give them that support. We're not
Even
going
the square pegs in round holes.
No, that is management. We are talking about the clinical teams, the doctors, the nurses, the allied healthcare professionals. Those are the ones that impact on patient care. Management is supportive of them, and I think that is what management and healthcare has to realize.
But that should make you very unpopular with some of your own colleagues, because if you're talking about cutting, totally severing
the food,
the transfers.
You're cutting the food, the money line.
Transfers in terms of getting services and so on in the private sector. That must have made you unpopular.
That is the minister's policy, and that is also my opinion. And I will tell you that when the private and the public sector, there should not be that level of outsourcing if you can build capacity, and the minister has insisted that we build capacity first, and that is first and foremost. You have to build back your healthcare system. When we were at a conference in the UK in December, and we were looking at different health systems, and then we had to present, and the Trinidad team, I presented our health sector here, our health system. We were judged as having still the best health system, the two-tier system with public and private. If you want to go private, you can afford to go private, you go private. But the country must provide public health care, no fees. That is still regarded as the best system. We need to improve it though. In the world. This was in the UK. Yes, because we maintain the old UK system. We maintain where everybody in a public healthcare system can access healthcare. The problem though is that we need to focus more on building it, rebuilding it, and increasing capacity. And the first way to do that is to ensure that your doctors and your nurses advise you on where to go, and that you start to audit. You need to audit data. You need to know what is affecting the people of our country. What are we treating, and therefore what are we going to provide? Are we going to spend $1 million US to take care of 35 to 45-year-old males with heart disease that can be put back out to work? We can take care of them, we can heal them, we can rehabilitate them, and they come back out to work. Or are we going to spend that $1 million US on a liver transplant and a child that may only survive 6 months after that? We have to prioritize spending. It is not unlimited.
Thank you. Thank you. We have to leave it there.
Sounding like the old empath lady now. Struggling.
I'm hearing the empath.
Struggling to balance,
Well, let me thank Dr. Lachman, Ms. Reno, and Matron Fraser.
And even this with you.
No problem.
And again, thanks to the chairman.
Thank you, Chairman. Pleasure. We need to have them back again.
I would love to have you back.
Yeah.
And, deal a little more extensively with some of the regional health issues. Thank you.
Looking at the list, Dale, I'm not seeing anything for dialysis here. Hold on.
That's centralized ministry.
I need for you to send me something on dialysis, Chairman.
I will
what you're
do
trying
that.
to do
Can you
with the
give us an account
dialysis
of
project.
how many dialysis machines are in the system as far as your...
As not central.
Yes.
I can do
Okay,
that.
Yesterday, people calling me about dialysis again, complaining.
Yes.
All these years.
Wait, not dialysis. Dialysis machine.
What did I
You
say?
keep saying dialysis.
Really?
Dialysis.
No, it's all over there, right? I think I'm saying dialysis.
Thank you,
I'm not.
ladies, for coming.
All right.
Thank you.
And that brings us to the end of the program.
Thank you all.
Thank
See you all
you for
soon
having
again.
us.
Pleasure.
And happy Mother's Day to you all.
Happy Mother's Day to all of you.
And thank you, mother.
Of 3 boys,
I
and
didn't know
one
when
did
that
SCA
happened.
yesterday.
All the mothers?
It all happened before I came
Happy
into
Mother's Day.
business.
My daughter did SES.
We both had kids with SCA.
All right. Well, congratulations. Bye-bye, everybody. Have a good
See you all
weekend.
on Monday. Take care.